Hello, this will be the continuation of your lecture on the responses to altered oxygenation. This is the lecture on cardiac and tissue perfusion and transport. So we have discussed your respiratory system. Now it's time to discuss the cardiovascular system. Please take note of this disclaimer that this recorded lecture is intended for Level 3 students of the Bachelor of Science in Nursing program. This lecture does not constitute medical advice, and parts of the discussion may not be suitable for the general public. This is augmented by live synchronous sessions for questions and answers that will be given to the students. If you have any questions regarding this recording, it may be emailed to the email address indicated on the slide. Now let's talk about the basic concepts on your cardio nursing. Why are we learning about your cardiovascular system? Your CVD or your cardiovascular disease is considered to be the leading cause of mortality, even in the US. It's the #1 cause of death in the US. The disease could cause more death compared to the next 4 causes of death all combined. So you have your cancer, chronic lower respiratory disease, accident, and diabetes. Combined with cardiovascular disease, there's still more death in cardiovascular disease. Other than that, your CVD is also considered to be the leading cause of death among women. Oftentimes, we think that men are at higher risk for cardiovascular diseases, but statistics would say that it is also the leading cause of death among women. Other than that, 40% of those who have MI die within 1 year from the initial cardiac event. Meaning, for MI or myocardial infarction, the prognosis of our patient tends to be poor also, because 40% would die within 1 year of the event. Now, when we're talking about cardiovascular system, it's composed of 3 main organs. The 3 main organs referred to here is your heart, your blood vessels, and then your blood. Now, when I talk about the heart, it is the muscular organ that pumps blood throughout the body. When I talk about blood vessels, these are your arteries and your veins. It should be instinctive to us right now that when I say arteries, it carries oxygenated blood, and when I say veins, it carries deoxygenated blood. Now, when I say perfusion, when the main function of your lungs is oxygenation, the main function of your heart is perfusion. Okay, when I say perfusion, it is supplying oxygen to your body organs, and that is through pumping blood towards your primary or your organs of the body. Any problem that can occur in your cardiovascular system might result to a life-threatening condition because this would alter oxygenation and perfusion. This would alter again oxygenation and perfusion. Now, as nurses, we need to remember that most of the clients we see will have the risk factors and clinical manifestations for cardiac disorders. That's why we need to be mindful of this assessment. Now, let's talk about the review of anatomy, physiology, and the functions of your cardiovascular system. The heart. The quick estimate of the size of your heart is that of your fist. It's considered to be a hollow muscular organ which is located at the center of your thorax. It occupies that space that you refer to as mediastinum, and we know that mediastinum is just between your lungs. Your heart approximately weighs 300 grams. Now, your heart pumps about 60 ml of blood. That is about 5 liters per minute. Let's talk about some of the factors influencing the size of the heart. You have your age, gender, body weight, extent of physical exercise and conditioning, and then you also have your heart disease. Let's talk about the role of aging on the size of our heart. Okay, when I talk about elderly, the tendency of our elderly patient is to have undergone hypertrophy. Okay, when I say hypertrophy, meaning there is enlargement of the size of the organ. Particularly for the heart, there are thickening of the heart walls. Because of this increase in size, there will be changes in the myocardium. Later on, we will know that myocardium is the muscular part of your heart. With this thickening of the heart walls, there is reduction in the strength of the contraction. Okay, there is reduction in the strength of your contraction. Related to that reduction on strength, the blood flow will be decreased. Blood flow will be decreased to other parts of the body. The blood flow will be decreased also in the coronary circulation. And with that decrease, we are also expecting a decrease in your cardiac output. Okay, there will be decreases also in your cardiac output. Also, one particular change among elderly is that the valve tends to stiffen and no longer close properly. Okay, your valve will stiffen. Example of this valve, maybe your tricuspid valve, you will have your mitral valve. The tendency of this valve is to be thickened. When this valve is thickened, there is no more effective valve to stop the backflow of the blood from the ventricle, for example, going towards your atrium. That's why the tendency for your old patients is to present with regurgitation. Okay, the tendency is for them to present with regurgitation. When I say regurgitation, that is the backflow of your blood from the lower chamber to the upper chamber. Okay, please take note of that. Now, also because of age-related changes, it takes time for the body of an old adult patient to compensate from the increased metabolic demands due to stress, exercise, or illness. Unlike compared to the young, healthy adults, they have the tendency that if they are having exercise, their heart will just beat fast in order to compensate for the needs of the body. But for the old adults, they will have difficulty to adjust on the cardiovascular changes. Now, let's talk about your pericardium. Okay, your pericardium is a thin fibrous sac that covers and protects the heart. So when I say thin fibrous sac, if your lungs would have the pleura, for your heart you would have your pericardium. Now, your pericardial cavity, just like that of your lungs, would have the the visceral pericardium, and then you have the parietal pericardium. So visceral, as we have said, V is very close. So you have visceral pericardium, which is close to your heart. Then you have your parietal epicardium. Your parietal epicardium would surround or envelop your visceral, your tough fibrous tissues, your diaphragm, your sternum, and even your vertebral column. So it is the one that supports the heart in your mediastinum. If the pleural cavity would have 5 to 15 ml of fluid, here for your pericardium, you would expect that there will be 20 ml of fluid that would lubricate the surface of the heart and also reduce friction. Let us talk about the three layers of your heart. The first layer is your epicardium. Your epicardium is the outer layer or the outermost layer. So it's referred to as epi, just like your epidermis, it's the topmost layer. Now when I say myocardium, your myocardium, other than being the middle, myocardium, middle, remember it's also the muscle. Hence, it is responsible for the pumping action. Then you have your endocardium. Your endocardium, endocardium maybe, is your inner layer. It is lining the inside of your heart and the valves. So take note, epicardium, myocardium, and endocardium. Now let's talk about the septum. Your septum is the muscular wall that separates your heart into the two halves. You have your right and your left. Okay, so your septum is located here. Remember, it is a muscular wall. Now, let's have the four chambers of your heart. The four chambers of your heart are your right atrium, right ventricle, left atrium, and left ventricle. So the pumping action of your heart is accomplished by the rhythmic relaxation and contraction of the muscular walls of its chambers. So take note, there is rhythmic relaxation and contraction. If your heart is not relaxing, your heart cannot be filled with blood. If your heart is not contracting properly, your heart will not be able to pump blood out of the body. Okay, or pump blood out of the heart in such a way that it will reach your vital organs. Again, if there is a problem in relaxation, you will have a problem on the feeling of the heart. If there's a problem with contraction, you will have a problem on the blood reaching the vital organs of the body. Let's talk about the four chambers one by one. Okay, now let's discuss the right side. Remember that your right side is the one that distributes deoxygenated blood to the lungs. It is the part that receives your deoxygenated blood. Okay, right side, deoxygenated. Left side will be oxygenated. Since your right side contains blood which is deoxygenated, it is also the same side that places your deoxygenated blood towards the lungs for it to become oxygenated. Now, let's talk about the right atrium. Your right atrium is the one that receives venous blood returning to the heart. So your right atrium is receiving blood from your superior vena cava, receiving blood from your inferior vena cava, and then another one is your coronary sinus. So when I talk about superior vena cava, these are blood which came from your head, the neck, and the upper extremities. When I say inferior vena cava, we are looking at the lower part of the body. So these are blood that came from the trunk and then the lower extremities. Whereas when I say coronary sinus, your coronary sinus would come from the cardiac or coronary circulation. When I say coronary circulation, this is the blood which nourishes, which gives oxygen throughout the entire heart musculature. Okay, that will be done by your coronary sinus for the venous functioning. So again, right atrium receives blood from the superior vena cava, the inferior vena cava, and then your coronary sinus. Most of this venous return would flow passively from the right atrium, going towards your valve, going towards your right ventricle during your diastole. Okay, during your diastole. Now, you will recall that the valve here on the right side is your tricuspid. Just remember, R is near with T or near to T, right, tricuspid. Left, L, mitral. Okay, L, M, mitral. Now, let's talk about your right ventricle. Your right ventricle is also a muscular pump located behind your sternum. If you can recall the location of your heart, okay, the middle part of the heart, or commensurate to the location of our sternum is actually the right side of your heart, because the big part of your heart is inclined on the left side. That's why your right ventricle is defined to be a muscular pump located behind the sternum. It generates enough pressure, okay, later on to close your tricuspid valve and open your pulmonic valve to push the blood going towards your pulmonary artery. Take note, your pulmonary artery is the only artery, okay, the one and only artery that carries deoxygenated blood. Okay, then it will go towards your lungs. Now again, so from the right atrium, it will go towards your right ventricle. After your right ventricle, it will be going towards your lungs. Here, we'll be talking about your left atrium. So remember, your left side again carries oxygenated blood. So it would have higher pressure compared to the deoxygenated blood. Now, the left atrium is the one that receives the oxygenated blood from your pulmonary vein. The only vein that carries oxygenated blood. Okay, your left atrium is the one that carries or receives oxygenated blood from your pulmonary vein. Then you have your left ventricle, which receives the blood from your left atrium and then distribute the blood to the body. Now, just as a simple recall of the circulation, you know that it will first go to your right atrium, going toward your tricuspid valve, going towards your right ventricle. And then after your right ventricle, it will go towards your pulmonic valve, going towards your pulmonary artery, going towards your lungs. From the lungs, it will return to the left atrium that will be through your pulmonary vein. From the left atrium, it will go towards what valve? Mitral valve that will go towards your left ventricle. And from the left ventricle, it will go towards your aorta. Okay, that's a simple recall of how your circulation takes place. Now, let's talk about diastole and systole. Okay, so you have your diastole and systole. When I say diastole, the best thing for you to remember is that diastole is the relaxation phase. Okay, diastole is relaxation phase. Since it is the relaxation phase, what happens during the diastole is that all the four chambers of the heart are relaxed simultaneously. Since they are relaxed, it would allow for what you refer to as ventricular filling. When I say ventricular filling, meaning it allows for the blood to fill your ventricles. Okay? Hence, it is preparing your heart for contractions. When I talk about diastole, one thing also that you need to remember is that your diastole is represented by the P wave. Your diastole is represented by your P wave in your ECG. Now, let's talk about systole. When I say systole, your systole refers to contractions. Okay, the heart is working. It's the time with a higher pressure. This refers to the events in the heart during contraction of both your atrium and then your ventricles. Now, what happens is that your atrial and your ventricular systole are not simultaneous. Okay, earlier we said that both the atrium and the systole are relaxed simultaneously. However, during the ventricular systole, they are not simultaneous. It is the atrial systole that occurs first, meaning your atrium would contract first, just at the end of the diastole that will be followed by your ventricular contraction. Okay? This allows your ventricles to be completely filled prior to the ejection of blood to the chambers or from these chambers. Okay? And during ventricular systole, the right and the left ventricle must overcome the resistance to the blood flow from both pulmonary and systemic circulatory system. That's why if you can notice in your blood pressure, there is a higher pressure for your systole over your diastole, because it reminds us that during your systole, your chambers of the heart, especially your ventricles, would need to fight the pressure of the systemic and then the pulmonary circulation for the blood to reach the periphery. Then, take note that your ventricular systole is indicated electrically by your QRS complex. It is indicated by your QRS complex. Now, as a quick review again, if I talk about diastole, your diastole is the time that your heart is relaxed. Diastole, heart is relaxed. If I would look at the sound, if it is slob or dub, your diastole is represented by the dub. Okay, represented by the dub. And then systole. When I say systole, it is the time wherein the ventricles are contracted. This is represented by your lung. And this one is represented by your QRS complex in the ECG. Okay, if you would look at the slide, if you would look at that highest wave that can be seen, that is already your QRS complex. It is referred to as QRS because this is your P, Q, R, S, T. That's why it's referred to as QRS complex, because it is where your point Q, R, and S are. Okay? Talk about your heart valves. For your heart valves, there are two main kinds. You have your atrioventricular valve and then you have your semilunar valve. As the term implies, atrioventricular valve or AV valve is the valve between your atrium and your ventricles. There are two main valves for this type. So you have your tricuspid valve and your mitral valve. For your tricuspid valve, as the term implies, tricuspid, meaning there are three leaflets. That's why it's referred to as tricuspid. It separates your right atrium from your right ventricle. And then your mitral valve, as the term implies, mitral, okay, bicuspid. This is bicuspid valve, also known as bicuspid, meaning there are two leaflets. It separates your left atrium from your left ventricle. Now, what do you think happens to the atrioventricular valve during diastole? Remember, when I say diastole, diastole is commensurate to the relaxation of your heart. Diastole, relaxation. And during relaxation, we want the ventricles to be filled with blood. Since we want the ventricles to be filled with blood, what do you think happens to the atrioventricular valve? Will it be open or closed? So during diastole, your atrioventricular valve tends to be open. It needs to open in such a way that the blood from the atrium will go towards your ventricle. Because again, remember, diastole. Diastole is relaxation of your heart. Relaxation of your heart is your ventricular filling. So for the ventricles to be filled with blood, your AV valves need to be open during your diastole. Then, as your ventricular systole would begin, the ventricles are expected to contract, and then the blood flow will flow upward into the cusp of the tricuspid in your mitral valve, causing them to close. So again, once the blood already filled your ventricles, what happens is that the blood that filled the ventricles will be pushed upward, which will close your valves. Okay, it will close your valves. Then this closure is being maintained by your papillary muscle and then your chordae tendineae. okay, your papillary muscle, and then your chordae tendineae. During ventricular systole, the tendency is that there will be contraction of your muscles, which would keep the valve leaflets taut, approximated, and close. Okay? This prevents backflow of the blood into the atria. Again, during your ventricular systole, when I say systole, your heart will be working. Meaning during your ventricular contractions, this valve is maintained to be closed. It is closed in such a way that by the time that your ventricles will exert effort to push blood out of it, the blood will not backflow towards your atrium. It prevents your regurgitation or backflow, as the blood will be ejected out to your pulmonary artery, okay, if it is from the right side, and then through your aorta if it is from the left side already. Now, let's talk about your semilunar valve. Your semilunar valve are already composed, all of them are composed of 3 leaflets. Okay, look at this picture. You have 2 semilunar valves. You have your pulmonic valve and then your aortic valve. Looking at this picture, okay, they both contain 3 leaflets. Now, your semilunar valve is expected to be closed during diastole. Because remember, in diastole, we have relaxation of the heart, ventricular filling. If you want to fill the ventricles with blood, you don't want the blood to escape yet. So you would want your pulmonic valve and your aortic valve to be closed. Okay, at this point in pulmonary artery, the pressure in your pulmonary artery and the aorta tends to decrease. Okay, so during your ventricular systole or diastole, during diastole, the tendency of your blood is to backflow a little bit from your aorta and from your pulmonary artery. So this valve, okay, that backflow or stays on the lower part of your pulmonary artery allows for the closure of your valves. The semilunar valve are first open, during ventricular systole, as the blood is ejected from the right and left ventricle into the pulmonary artery and aorta. To recap, our heart is composed of 4 valves. Okay, as a reminder, once the valve is open, it will allow the blood to flow through. Once the blood is in the specific chamber, the tendency of the blood is to push the valve upward. Okay, that push would allow the valve to close. And then the valve is maintained to be closed by your papillary muscles and your chordae tendineae. So remember that during ventricular filling or your diastole, in diastole again, diastole is ventricular filling. So for the ventricular filling to occur, your atrioventricular valves are open, but your semilunar valves are closed. So just as a quick recap, in the right side, you have your tricuspid valve and then your pulmonic valve. On the left side, you have your mitral valve and then your aortic valve. Let's talk about the cardiac muscles. Your cardiac muscles, okay, specifically your myocardium, this is the middle muscular layer of your cardiac walls. We have the term myocytes. Your myocytes are the specialized cells found in your heart which form an interconnected network of muscle fibers. Your cardiac muscles are connected to each other by a specialized junction that we refer to as your intercalated disc. Okay, look at the picture. This is the one that illustrates your intercalated disc, which connects our cardiac muscles from one another. Okay, on the right side, you have the microscopic image of your intercalated disc. This allows the cardiac cells to contract in a wave-like pattern so that the heart can work like a pump. Okay, without a constant supply of oxygen towards our heart, remember, if there will be a problem in our coronary circulation, your myocardial infarction or your heart attack may occur. Let's talk about the properties of your cardiac muscles. So in the slides, there are 5 properties of the cardiac muscles. So if you would try to memorize the properties, it can be summarized by the acronym CARE. Okay, take note that there will be double C there, so CARE. You can have conductibility, contractility, refractoriness, and then automaticity, and then excitability. Now let's try to define them one by one. When I say automaticity, it is the ability to initiate. The key word there is initiate, electrical impulses. Okay, so your heart has the capability to initiate electrical impulses through your SA node. Excitability. When I say excitability, it is the ability to respond to an electrical impulse. Meaning by the time that your SA node would fire an electrical impulse, your heart will be able to respond. Hence, excitability. Then you have conductivity. When I say conductivity, it is the ability to transmit. Okay, remember, conduct. When I say conduct, conduction, transmission of electrical impulses from one cell to another. That's why it's referred to as conductivity. Then you have contractility. Your contractility, contract, meaning it is the tension. Contraction is equal to tension. It is the tension developed and the velocity of shortening of your myocardial fibers. Okay, so this one, the shortening of your myocardial fibers would determine also the strength of your contractions. Then you have the term refractoriness, or refers to refractory period. In refractoriness, this refers to the cardiac action potential and the repeated cycle of your depolarization and repolarization. So when I say depolarization, you should remember that this is the exchange of ions that creates a positively charged environment inside the cell. Again, depolarization creates a positively charged intracellular space and a negatively charged extracellular space. On the other hand, you have the term repolarization. The term repolarization, resting phase. Okay, so this happens after the action potential has been initiated. So we have the term refractory period. When I say refractory period, this occurs during the repolarization phase or the resting phase. Your refractory period refers to the inability of the cell to respond to any stimulus. Meaning during the refractory period, regardless if your SA node, AV node is firing some electrical impulses, your cardiac muscles will not be able to respond because it's the refractory period. This abolishes the excitability during this period of time. The purpose of your refractory period is to allow the heart to rest a little bit, for the heart to be filled with blood and what is known to have your cardiac cycle. Now, there are two kinds of refractory period. You have your absolute refractory period and then your relative refractory period. In your absolute refractory period, the cardiac excitability is totally cancelled. Whereas in your relative refractory period, your heart is beginning to recover gradually until it reaches its normal value. So, will you be able to notice your refractory period? No. Your refractory period would only take some milliseconds. Now, let's go to the conduction system of your heart. We've been talking about the electrical impulses. So, the electrical impulses in your heart are being transmitted through your conduction system. Your conduction system generates and transmits electrical impulses that stimulate the contraction of your myocardium. So, you have four. You have four terms there that you need to remember in the conduction system of your heart. First is your SA node, then you have your AV node, followed by your bundle branches, and then you have your Purkinje fibers. Let's go over them one by one. When I say SA node, your SA node is considered to be the primary pacemaker of your heart. Take note of the term primary pacemaker. Okay, this is why that if you have problem with the heart rate of your patient, we usually give or implant a pacemaker to our patients. We are helping the SA node, which is actually the primary pacemaker of your heart. Okay, the term is SA. SA stands for sinoatrial node. This tells us the location of your SA node. Your SA node could be found between the junction of your superior vena cava and then your right atrium. That's why it's referred to as sinoatrial node. Your sinoatrial node has the highest firing rate of 60 to 100 impulses per minute. Okay, this is in response to the metabolic demand of your body. Now, look at the rate, 60 to 100 impulses per minute. That translates to your normal heart rate, which is 60 to 100 beats per minute. Meaning if your SA node is functioning properly, you will get a heartbeat of 60 to 100 beats per minute. Next, you have your AV node. Your AV node is the secondary pacemaker of your heart. The term implies atrioventricular node, meaning it is between your atrium and your ventricles. It says that the location of your AV node is in the right atrium near already your tricuspid valve. So that's your AV node. The firing rate of your AV node is 40 to 60 impulses per minute, corresponding to a bradycardic rate of 40 to 60 beats per minute. So what do we mean by that? Whenever your SA node is damaged, whenever your SA node is not able to do its task, your AV node will try to take over. So oftentimes, patients with damaged SA node would only have a heart rate of 40 to 60 beats per minute. Hence, if you have patients encountering bradycardia, you might consider that your patient's SA node is already damaged and it is the AV node taking over. In this case, depending further evaluation, your patient may have a pacemaker implant. Your pacemaker implant will act as the SA node of your patient. Now, so from SA node, it will go towards your AV node. After your AV node, it will go towards your bundle branches. Your bundle branches is divided into two. You have your right and your left bundle branch. They transmit the impulse from your AV node to your ventricles. Then you have the term Purkinje fibers. Your Purkinje fibers is considered to be the terminal point of the conduction system of the heart. Terminal point because that is the last point where the electrical impulse would go. Terminal, it's the end point. It initiates and coordinates the signal that causes the rhythmic and synchronized contractions of your atria and ventricles. Your Purkinje fibers are specialized conductive myocardial cells. They can promote rapid conduction of the impulse through the ventricles. So if you would look at the illustration, your Purkinje fibers are located already on the ventricles. Okay, they are primarily lined on the ventricles. The purpose of that is to promote the contraction of your ventricles. So once again, if there will be a malfunction of your SA node, it will be the AV node that will take over. Your AV node might be able to sustain vital functions within some time. However, if your AV node would fail, your bundle branches and your Purkinje fibers will not be able to sustain vital functions because their rate is at less than 40 beats per minute. Okay, so try to remember that. SA node, AV node, then you have your bundle branches going towards your Purkinje fibers. This slide simply illustrates the conduction system of the heart. So from the SA node, the electrical impulses are fired towards your AV node. From the AV node, it will go towards your left and right branches, going towards your Purkinje fibers, which are highly excitable cells. Let's talk about the factors influencing the conduction of your impulses. The first one is your parasympathetic nervous system stimulation. So when I talk about parasympathetic nervous system, what would be the effect on the heart rate? So when I say parasympathetic, it has the tendency to decrease your heart rate. And when I talk about parasympathetic nervous system, remember this is the stimulation of your vagus nerve. Okay, vagus nerve. Then you have your SNS stimulation. You have your sympathetic nervous system. When I say sympathetic nervous system, that is your fight or flight response. So what is the effect of your fight or flight response on your heart rate? The possibility is for your heart rate to be increased. So in your SNS or your sympathetic nervous stimulation, what happens is that the beta 1 receptors which are present in your SA node are being stimulated. If you can recall, beta 1 acts on the heart, beta 2 acts on your lungs. So in your sympa, your beta 1 is being innervated, being stimulated, leading towards the increase of your heart rate. Because again, the beta 1 receptor is located just near your SA node. So SA node, the primary pacemaker of your heart. Exercise. We know that exercise could increase our heart rate. By now, we should understand that exercise triggers the release of your epinephrine and norepinephrine. And when you hear epinephrine, norepinephrine, they stimulate the receptors of the heart, which causes the heart to increase also their rate. Let's go to age. For age, we know that as one ages, hypertrophy of the heart occurs. When hypertrophy of the heart occurs, the heart tends to become ineffective. The contractions of the heart tends to become ineffective. With age also, we should also note that the heart rate becomes slower. Okay, this slowing of the heart rate is because of the diseased sinoatrial node or SA node that our old patients usually undergo. Then, they have the tendency to take longer to compensate on increased metabolic demands. What do you mean by that? If your patients would have hyperthermia among old adults, the tendency is for us to become tachycardic. Among young adults, it will be a normal response for them to become tachycardic if exposed to stress. But for old adults, their tendency is that their body will take some time to become tachycardic in order to compensate with the needs of the organs. So again, it takes longer for them to compensate on increased metabolic demands. Then they have the tendency to have arrhythmias. So when we say arrhythmia, your arrhythmia is any abnormality on the electrical impulses on the heart. It may be on the rate and the rhythm. So arrhythmia, there may be a problem on the rhythm of your heart. If your patient has problems on the rhythm, they may manifest with signs such as palpitations, shortness of breathing, dizziness, and fainting. The dizziness and fainting is brought about by the decreased oxygen that goes towards the brain. Once there is decreased oxygen going towards the brain, resulting to dizziness and fainting. Electrolytes. Under fluids and electrolytes, we have understood that your potassium and calcium has a significant role in your cardiac contractility. Now, since we have potassium and sodium are opposite electrolytes, calcium and magnesium are also enemies. So you should remember potassium, calcium. Then along with potassium, you have sodium. Along with calcium, you have magnesium. Any abnormality in these four electrolytes could cause abnormality in our cardiac contractility. Hence, if your patient would have cardiac problems, we would usually rule out these causes first before treating the patient. Temperature. As mentioned, hyperthermia leads to tachycardia. Hypothermia also leads to cardiac dysrhythmias. Then you have hormones. For your hormones, you have your catecholamines. So catecholamines are produced by your adrenal glands. So whenever there are increase of your epinephrine and norepinephrine, your cardiac rate is also expected to be increased. Another hormone that we need to look into is your thyroid hormone. That's why among patients with palpitations, we usually evaluate the patient's thyroid hormone levels, because patients with hyperthyroidism has the tendency to manifest with tachycardia and palpitations. Because when I talk about patients with hyperthyroidism, their metabolic responses are also hyper. So those are the three hormones. Catecholamines, including your epinephrine, norepinephrine, and then you have your thyroid hormone. Now let's talk about the cardiac output. Remember that the term cardiac output refers to the amount of blood pumped from the left ventricle each minute. Again, highlight there the term each minute. So cardiac output, the formula is heart rate times stroke volume. So because it refers to each minute. Now, when I say stroke volume, that is the amount of blood which goes out of your ventricle every time the heart pumps or every time the heart contracts. So if you want to determine the cardiac output, it needs to be heart rate, which is of course the rate of your heartbeat every minute times your stroke volume. The resting cardiac output is at 4 to 6 liters per minute. So imagine your heart is pumping about 6 liters of blood every minute. Now, heart rate. When I say heart rate, it's the number of contractions again each minute. We know it's 60 to 100 because you can recall what is the primary pacemaker of the heart again? Your SA node. SA node is the primary pacemaker of your heart. Okay, and the normal resting firing rate of your SA node is 60 to 100 beats per minute. As a compensatory mechanism, your heart rate may also increase. However, you need to note that once the heart rate increases, the demand of oxygen of the myocardial tissues also increases. Okay? With that, it also increases the risk of your patient towards tissue ischemia. Your heart rate is controlled by your autonomic nervous system. So your autonomic nervous system is divided into two. You have your parasympathetic and then your sympathetic nervous system. For your parasympathetic nervous system, one particular nerve there that you need to remember is your vagus nerve. And then you also have your sympathetic system. Okay, remember your beta receptor site. Stroke volume. As mentioned, stroke volume is the amount of blood ejected by your left ventricle during each contraction. Okay, so meaning it's the amount of blood that goes out of your left ventricle every time it contracts. These are the variables that would affect your stroke volume and your cardiac output. You have your preload, afterload, and myocardial contractility. Your preload is the amount or the degree of myocardial fiber stretch at the end of diastole. It is also referred to as the amount of blood within the ventricle at the end of the diastole. Okay, meaning it is the amount of blood present inside your ventricles after ventricular filling. Think of your preload and afterload as the workload of your heart. So when I say preload, it is the load of your heart before it pumps. Afterload. Afterload is the pressure or resistance that the ventricles must overcome to eject blood through the semilunar valve. Okay, meaning it is the pressure that your heart needs to fight for the blood to go out of the heart. So typically, these are the pressures present in your semilunar valve, your pulmonary artery, and then your aorta. If you would look at the illustration on the right side of the slide, your preload is shown as the volume of blood at the ventricles at the end of your diastole. Okay, so this is affected by hypervolemia and regurgitation of cardiac valves, and even your heart failure. These conditions can increase your preload. So hypervolemia is fluid volume excess. If your patient has fluid volume excess, there will be an increased workload for your heart. Regurgitation. If some of the blood is coming back, to the respective ventricle, there will be a lot of volume that this ventricle needs to work on, hence increasing the preload. And then heart failure. There's left-sided and right-sided heart failure. Afterload. So it's the resistance that ventricle must overcome to circulate blood. In this case, it is illustrated as the pressure in your aorta. Okay, so if there is vasoconstriction, if there is hypertension, meaning there is increased pressure in the systemic aspect, there will be an increased pressure that your heart needs to push in order for the blood to go out of the left ventricles and then for the blood to go to the respective organs and the periphery of the body. Okay, so again, increase in the afterload is also an increase in your cardiac workload. Later on, if this cardiac workload will continue to increase, it will result to heart failure. Then you have myocardial contractility. Your contractility is the contracting power of your heart, and this is enhanced by your catecholamines, your sympathetic neuronal activity, and then certain medications, such as your digoxin. Remember that your digoxin slows down your heart rate, but it makes your heart pump more effectively. Let us review some of the factors that might affect the preload, afterload, and contractility. For the preload, remember that the preload is the amount of blood present in the ventricles at the end of the diastole. That's why your preload is also referred to as ventricular and diastolic pressure. Let's talk about diuresis. When your patient is taking diuretics, what happens to the amount of blood? The blood volume is decreased. Okay, because of that, your preload is also expected to decrease. Nitrates. Your nitrates, such as your nitroglycerin, are considered to be vasodilators. Okay, they are vasodilators. So as vasodilators, what is the effect of vasodilation towards your preload? When there is vasodilation, or specifically venodilation, okay, dilation of your veins, the tendency of the blood is to pool in your veins. Hence, it also decreases your blood volume towards the heart. Hence, your nitrates decreases the preload. Blood loss. If there is excessive blood loss, it decreases the volume, hence also decreasing your preload. So as your dehydration. Then, IV administration. If you are administering IV fluids to your patient, what happens to the volume of the blood? The volume will increase. Hence, preload will also increase. Blood transfusion. Infusing blood is as good as administering IV fluids, so your blood transfusion also increases your preload. Remember that for your preload, you have what we refer to as your Frank-Starling principle. According to this principle, the greater the volume of blood entering the heart during diastole, the greater the volume of blood ejected during systole. Okay, so there is a direct relationship between the amount of blood that enters your heart and then ejected from your heart. Now, afterload. As we say, afterload is the amount of pressure that the heart needs to overcome in order to pump the blood out of the heart. So, common example is your aortic pressure and then your pulmonic artery pressure. Now, blood viscosity. If the blood is more viscous, what's the tendency? Does the heart need to exert more effort or less effort? The heart needs to exert more effort. Hence, the afterload is increased. If there is hypertension, meaning there is increase of pressure in the systemic vasculature, what will happen? Will the heart exert more effort or less effort? So the heart will exert more effort for the blood to go on that specific area. So your hypertension also increases your afterload. Contractility. When I say contractility, it's the ability of our heart to contract, or for the cardiac muscles to contract, as initiated by your SA node. So we have your catecholamines. When I say catecholamines, okay, it increases, it stimulates your heart. So your catecholamines are known to increase your contractility. Then you have your SYMPA activity, of course, and then certain medications such as your digoxin, dopamine, and dobutamine. We know that digoxin is a cardiac glycoside. Being a cardiac glycoside, it decreases our heart rate. However, it makes each contraction to be more effective. It increases the strength of every contraction. That's why your digoxin, along with your catecholamines, dopamine, dobutamine, are expected to increase contractility. On the other hand, hypoxemia. When we say hypoxemia, there is decrease of oxygen in the bloodstream. If there is decrease of oxygen in the bloodstream, the tendency of the heart is to work. Will it become more effective or less effective? The tendency is for the cardiac workload to become less effective, or for the cardiac muscles to become less effective. Hence, hypoxemia decreases contractility. So as your acidosis. Okay, when I talk about beta blockers, remember that when you stimulate beta 1, when beta 1 is stimulated, the heart rate tends to increase. But right now, we're talking about beta blockers, meaning beta 1 is blocked, or the beta receptors are blocked. Since they are blocked, what happens to the heart rate? The heart rate decreases. What happens to the contractility? The contractility also decreases. Okay, if you can recall, your beta blockers are medications that ends with olol. Okay, so for example, we have patients with propanolol, prescribed with propanolol if they have palpitations. The function of this medication is to enhance the contractility, to slow down the contractility of the heart. Okay, so you have your beta blockers. Then we have the term ejection fraction. If you have undergone to the echo, you might have heard of the term ejection fraction. Your ejection fraction is usually measured through a diagnostic study such as your 2D echo. So for your ejection fraction, it is the percent of the end diastolic blood volume ejected with each heartbeat. Meaning, if there is 100% of blood present inside your ventricles, your ejection fraction would answer the question, how many percent of this blood will go towards your system? How many percent of this blood will go to your system? Okay, the amount of blood or percent of blood ejected by each heartbeat. So your ejection fraction has the normal value of 55 to 65. That would mean that not all of the blood present inside your ventricles would go out by the time it will be contracting. Then we have the cardiac cycle. But before that, also it's wise for you to remember that an ejection fraction of less than 40% is already an indication of your heart failure. Again, an ejection fraction of less than 40% is already considered to be heart failure. Now, let's go to the cardiac hemodynamics. The cardiac hemodynamics is being controlled by your cardiac cycle. Your cardiac cycle are the events that occur in the heart from the beginning of one heartbeat to the next. Okay? Important thing here that you need to remember is that the determinant of the blood flow in the cardiovascular system is the principle that the fluid flows from a region of higher pressure to one of lower pressure. So your cardiac cycle is composed of three major sequential events. So sequential meaning they come in order. First, you have your diastole. Then you have your atrial systole, and then your ventricular systole. Let's discuss them one by one. So when I say diastole, you should remember by now that diastole is the relaxation of your four chambers. This happens simultaneously. The atria and then the ventricles relax at the same time. The purpose of your diastole is to feel the ventricles. Again, ventricular feeling. So what happens? If you want to feel the ventricles, what do you want to do with the AV valve? You won't want the AV valve to be open in such a way that the blood from the atrium will go towards the ventricles. What would you want with the pulmonic valve and then the aortic valve? Okay, you would want these valves to be closed because you don't want the blood to escape the ventricles just yet. Okay, so in your diastole, remember that your atrial valves or atrioventricular valves are closed, whereas your semilunar valves, in your diastole, I mean your atrioventricular valves are open and your semilunar valves are closed. Now, for the right side of the heart, all of those blood from your superior vena cava, inferior vena cava, and then even your coronary sinus would return to your right atrium. And on the left side, the oxygenated blood now returns from the lungs, okay, going towards your left atrium. So this signals your diastole. Now, let's go to atrial systole. If you can recall, the atrial systole occurs first by some milliseconds before we go to your ventricular systole. Your atrial systole, or this synchronicity in the movement, would allow your atrial, okay, or your atrium to push some blood going towards your ventricles. Okay, so this occurs towards the end of your diastole. This is first started by the firing of your sinoatrial node. Then the atrial muscles would contract in response to your SA node firing, and then there will be increased pressure inside the atria. And because of that increased pressure, the blood will be ejected to the ventricles. Then in ventricular systole, with the firing of your SA node, what happens is that the pressure within the ventricles will also increase. As mentioned earlier, once the valve is open and then the blood will rush already towards the ventricle, the blood will close the valves or your AV valves. And then your ventricles will be about to contract, hence the semilunar valves will be open. And then the blood will go towards your pulmonary artery if it is from the right side, and then it will go towards your aorta if it is on the left side, meaning it's going out to the system after fighting your afterload. Then we have the term coronary circulation. So we know that the heart provides blood to all parts of the body. But the next question is, who provides blood to the heart itself? Okay, so you have what you refer to as your coronary circulation, meaning this is the blood supply of your heart. So you have two major arteries that you would want to know. You have your right coronary artery, then you have your left coronary artery. Your right coronary artery is the one that supplies blood to your right atrium and then anterior of your right ventricle. Okay, so it supplies the posterior aspect also of your septum, your posterior papillary muscle, your SA and your AV node, and then the inferior aspect of your left ventricle. Okay, on the other hand, you have your left coronary artery. Your left coronary artery is divided into two parts. You have your left anterior descending, and then you have your circumflex artery. Take note, your left anterior descending would supply anterior left ventricular wall, anterior interventricular septum, anterior papillary muscles, and then left ventricular aspect. On the other hand, your circumflex artery would supply blood to the left atrium, posterior surface of the left ventricle, and then posterior aspect of the septum. Why do we need to familiarize these parts of the heart which are being supplied by these arteries? Okay, for example, if there will be a problem on the right coronary artery, okay, if there will be a problem on the right coronary artery, you would look into it that the right atrium functioning might be affected, so as the right ventricle functioning. Okay, that is because there might be a blockade in your right coronary artery. So, knowledge about this circulation would help us understand what will be the effects of a certain block to a certain artery. Now, so this is your normal heart, reminding you of the blood flow. Okay, so remember in your pulmonary circulation, from the right atrium, it will go towards your right ventricle, going towards your pulmonary artery. Through your pulmonary artery, it will go towards your lungs. And then from the lungs, it will return through your pulmonary vein. Pulmonary vein is the only vein that carries your oxygenated blood. And then from that, it will go to your left atrium and then your left ventricle. So, this will undergo already systemic circulation. From the left ventricle, the aortic valve shall open. It will go towards the aorta and then it will go towards different parts of the body. Okay, remember you have your ascending and descending aorta. And then after that, the blood will just return through your superior vena cava and your inferior vena cava going towards your right atrium. Okay, memorizing the circulation would be vital for you to understand the succeeding discussion for this topic. This will be the end of the first part of the assessment. Thank you very much for your kind attention.